Megan Nicholson, and I am the Director of Marketing at WellBe. We're happy you've decided to join us today for Optimize Your EMR for Orthopedics, essential strategies that drive patient engagement, financial success, and physician happiness. A few housekeeping details before we get started. This webinar is being recorded, and you should receive a link to the recording and the slides tomorrow by your email. Please feel free to share this webinar with colleagues who could not attend today. A question and answer session will immediately follow the presentation. If you have a question for our speaker, please type it into the questions box in your GoToWebinar panel on the right side of your screen. Today's webinar is sponsored by WellBe's Guided Care Path. The Guided Care Path helps create a single streamlined patient experience through the entire journey of a total joint replacement. It creates a continuum of connection between patients, their families, and their providers. Smart checklists are delivered just in time as patients progress through their care plans. The information is always there for reference when needed in case preparations or follow-up instructions are forgotten. This helps reduce patient anxiety and improve outcomes. For request a free demonstration, visit us at wellbe.me. Now I'd like to introduce our speaker for today. Joe Greene is currently the Program Manager of Outreach and Development for the University of Wisconsin Hospital and Clinic in the Department of Orthopedics and Rehabilitation. In this role, Joe coordinates business and philanthropic development activities for the hospital department and the university. In addition to his role with UW Hospital, Joe also is the CEO and owner of Orthopedics. Orthopedics is an orthopedic advisory firm that assists orthopedic practices of all types with operational and business development needs. Joe, I'm going to hand it over to you, and you can take it away.
Thank you, Megan. First of all, I want to say thank you to WellBe.me for sponsoring this event today and for letting me talk to you a little bit about some of my past experiences with electronic medical records and how I've been able to work with not only our own department, but especially a lot of other departments around the country and how they utilize them and hopefully make them much more effective for their physicians and patients. And so I wanted to start a little bit today by just having a few poll questions, and I'm going to cue Megan up to ask you those. I'd like to have some information up front so I know the types of people that I'm talking to. And so, Megan, I'll turn that over to you, but we've just got 3 quick poll questions we'd like you to answer.
All right, the first poll is up on your screen. We'd like to know, are you currently using an all-in-one system like an Epic or a Cerner, or are you using a best-of-breed system that's specifically built for orthopedics, like Phoenix Ortho, ChartLogic? So get your votes in now, and then we'll share what the audience is currently using. Like we've got 65% of the vote in. Those of you who are still hanging out there, just click one of the radio buttons, and we'll show the results. Okay, Joe, we've got 94% using an all-in-one, and 6% using the best-of-breed.
Okay, thanks.
So for our next poll, with most of you using an all-in-one, we'd like to know which system you're currently using, whether it be Epic, Cerner, Meditech, NextGen, or something else. So get your votes in now. This way Joe can talk a little bit more specifically about certain EMRs. All right, we've got 75% of you in. Come along, little stragglers. All right, Joe, we've got 35% with Epic, 18% each for Cerner and Meditech, 6% with NextGen, and 24% say other. So Epic's leading, which we probably knew was going to be the case. And then you want to do the third poll as well?
Yeah, let's do the third one right away, Megan, too.
All right, now we want to know at what stage of EMR utilization are you currently at? Are you implementing right now? Did you just go live in the last 6 months? Are you a year out or more than a year out? Everybody get your votes in now. It looks like the majority of people, 83%, are 12-plus months go live, 11% are 6 to 12 months, 6% are 0 to 6 months, and nobody is in the pre-implementation stage.
Okay, very good to know. All right, thanks, Megan, and thanks for your responses. I want to just give a little bit of background on myself, and I think Megan introduced most of that already, but I became very interested in healthcare information technology and electronic medical record utilization. A handful of years ago, we're very close in proximity to Epic, and just how a practice utilizes their EMR pre-implementation, after implementation, and then really how you leverage your EMR afterwards is just something that I enjoy learning about, and I believe is really challenging for most institutions to deploy. So a few years ago, I got the opportunity to start to do some consulting, and that was around workflows and staffing issues, and primarily orthopedic practices, and primarily large ones. And quickly the question arose is, well, we're going live on our EMR in a year, or we're already live and we're really struggling, and so I began to start to dig into this a little deeper and look to try and help, again, a lot of large practices, but certainly some smaller ones, about how to manage this better. So that's the genesis for my interest in this and my presentation today. What this presentation is not is a talk about how to implement your EMR from the IT side and about the technical aspects of an EMR implementation, but what it is and where my background is in what I believe is the best way to handle an EMR from an operational standpoint, and the approach that you should take as an institution, and how you can best manage your EMR moving forward, not only today, but also what it means in the future, and how you can really use your EMR and leverage that investment now, which is all very expensive, as you know, to your institution. So with that said, my objectives today are to help you appreciate a little bit about the current EMR landscape and what is happening. We'll spend a little time on that. I want to talk about the EMR and orthopedics specifically, appreciate the continuum of EMR adoption, and then I want to get to some of the specifics, which I think you're probably most interested in, about the operational aspects of how to handle an EMR, and then how you can work better with your IT department. Finally, I'll talk to some things that are going on now, depending on how mature your institution may be, but also a lot of forward-looking things with things that I'm working on right now within my own institution, and that I'm seeing a lot of other practices begin to adopt and try and work through. And none of this is real easy. It's really challenging, some of those higher-level workflows and how you leverage your data within your EMR to get the most out of it. So I want to first start by talking about the need for culture change, and the practices that tend to struggle the most with an EMR implementation and then subsequent optimization are those practices that are resistant to change. And I don't think that's a surprise to many of you, but it's going to come up a number of times in this presentation as far as whether this be your compliance department, whether it be your physicians, and what their resistance level is to trying new types of workflows, using their staff differently, and even changing other ways that they deliver healthcare overall to their orthopedic patients. And so I'll talk a good deal about that and its impact on the EMR also. As you know, the EMR is really just the skeleton and the backbone for how we deliver our care in this day and age. So the current electronic medical record landscape, the implementation environment is certainly stabilizing. As all of you know, there were tremendous incentives that were provided by our government over the last 4 to 5 years. That number is now 19.2 billion to almost 500,000 registered providers through the Meaningful Use program. So as more and more of our country and then eventually the world becomes live on electronic medical records, certainly that financial incentive will continue to diminish. And then we need to start looking at, well, how do we optimize and how do we use this to better take care of our patients. We're certainly seeing attrition and consolidation of vendors. I believe they're really going to start to shift to enhanced support and service. As they get live, they're going to demand more, or we're going to demand more from those EMR vendors as far as how customized their software is for us and the amount of support that they provide for us. How easy is it for it to use just from a navigation standpoint as well. So I think we're going to see a shift in a lot of the business approach that the vendors take, as most of this country, upwards of 85 to 90% is now electronic. And now that the larger vendors are going international to start looking at the largest health systems around the world. So we are going to see less competition for vendors or for institutions simply because of the amount of work that it takes to implement an EMR. As all of you know, it looks like all of you are really through those initial stages right now. So they're going to have to start focusing on keeping their customers. So right now, this is a quote, and I've got a quote from the current national coordinator. This is Farzad Nastashari, who is a general surgeon, Yale trained. He was asked by President Obama to start the Health Information Technology service for the U.S. Department of Health and Human Services. So he set up the initial structure. And this quote is just from last year. We are at about 50% EHR adoption, 5% workflow adjustment. And I really couldn't agree with this more. As the most common issues that I see in an orthopedic practice, and I believe handling an EMR well is probably 75 to 80% operational once you get through the initial implementation phase, is most practices haven't adjusted and they continue to put a great deal of work on their providers, and they haven't simplified workflows, whether their providers are doing it or whether their ancillary staff are providing it. And so he just left, and Dr. Karen DeSalvo, who is an internal medicine physician in New Orleans and worked a lot with the hurricane when it came there and how the city adjusted, she has taken over, I believe, as of January 1st. And she certainly feels very similar right now. This is a very recent quote on her talking about the usability of an electronic medical record, is that we have to make it easy for them and most importantly the nurses and other allied health providers to access critical information and to use the EMR. So she has just started in her role in Washington, D.C. These are some statistics from 2012 and 2013. This is provided by HIMSS, and these are current implementations that are going on or contracted implementations in the years 2012 and 2013. So these are all in one type software systems. You can see Epic is leading the closest competitor by approximately 3 times what Meditech and Cerner are right now. So I think most of you, if you follow EMR and implementation, is going to realize Epic is a large volume of this business and is kind of the giant in the industry, and are actually looking at where they're going to go for the largest hospitals next. But if we handle our EMR well, and all of our EMRs are up and running, which is going to happen in the next 3 to 5 years, is then we start to look at the things that you can get from your EMR that really benefit patient care and your business. And we'll start to move away from using your EMR simply to record transactions, which Epic and the other remaining software vendors are getting better and better at, to looking at all of these other areas that we can report on and how we can look at clinical activity and business activity to a greater extent. Because all of these areas in an all-in-one EMR talk to each other, whether it's recording clinical episodes or whether it's looking at the business and financial relationships and registration and access and all of those other types of areas of healthcare that are very important to administrators and physicians alike. So the vendors are really starting to get pressure from their clients to look at advanced levels of reporting and analytics, as well as being able to help improve their quality, safety, and outcomes. And we'll talk a little bit more about that towards the end of the presentation today. This is another quote that I thought is very applicable to today's presentation. is you can't just implement a software system by template and expect it to work well. And I think the institutions that adapt quickly and realize that changes need to be made have much earlier success than the others, and very thoughtful human process improvement and changes need to occur when you implement technology like this. And so we're going to talk specifically about orthopedics and those types of thoughtful process changes that I think are important, that I've seen benefit practices. A lot of this are things that I've learned within our University of Wisconsin hospital implementation. Epic is our software provider. But there are many things that I've learned from other entities and have applied. A lot of things that we don't do and that I wish we'd do better and that we're really still working on. And so my presentation today and the things that I will present you today are kind of a mixture of all of those past experiences and what I think may be best for you. So do these things sound familiar to you? The system is great for a family practice doc. It just isn't set up for an orthopedic surgeon. We have very different needs. I'm spending an extra 3 hours every clinic day completing my documentation and my orders. I'm an orthopedic surgeon. I want to be in the operating room, not spending all of my time documenting the system. My staff can't do what they used to be able to do for me once we moved to the EMR. I'm seeing 25% less patients than I used to be able to. I'm not happy and my life outside of work is being affected. Or in some cases, I've just decided not to see as many patients as I used to see. So these are things that I've written down as I've talked to physicians and what administrators have relayed on to me about the things that they see once they go live in their EMR. And I think what's really critical to appreciate and understand, and it should seem intuitive, is that orthopedics is different. And I am not by any means saying that other specialties should not be treated differently as well, but as you know, orthopedics is very high volume and high margin business with very competitive and driven physicians that are becoming increasingly specialized. And it would also seem intuitive that when you see 20 to 25 patients in a family medicine or primary care clinic, that when you see 45 or 50 or 60 in an orthopedic clinic, that the workloads are doubled. And when you couple that with the amount of volume and the amount of margin associated with orthopedics, you can see where these challenges not only impact the physician themselves, but also health systems overall, especially in businesses like sports medicine and spine that have really high margins and really high volume. So if these are impacted substantially, they have a big effect on the bottom line of any institution or independent practice. And so that's why I think orthopedics often does seem to have many more challenges than some other areas, but it's certainly not isolated to orthopedics, and other practices like dermatology and ophthalmology have similar types of physicians or similar types of problems, but they usually aren't as high margin, and so they get more, orthopedics tends to get more attention when they're affected negatively. I really believe that an EMR is an opportunity to look at a different way of doing something. And when we implement an EMR, when any institution implements an EMR, it magnifies some of the issues that were already present and that may have needed changes for a long time. Is that just as we've talked about, orthopedic practices have very high margin, high volume associated with them. And because of that, you kind of move along and you're doing pretty well. And then you move to something that really changes how you practice overall. And you have to make a lot of decisions about how you handle an EMR. And it certainly demonstrates the need not only to handle that EMR well, but also for you to think about different ways that you provide access to your patients, that you use your new appointment slots better for your physicians, that you're using your staff in the best way possible and the most cost-effective way possible. So I like to think of the EMR as a necessary sense of urgency. When you go live, it certainly has all the attention of your physicians and your staff, and in some cases you're very negatively impacted. So to look at it as a sense of opportunity to look at everything from a business development, service line development standpoint, I think is really important because it has to fit in with a new paradigm of service delivery. And so to look at your staffing, to look at your workflows, your access, your triage programs, your call center, all of those things at the same time I think is really healthy, whether it's before you go live or whether it's right afterwards, and that you're trying to make changes as quickly as you can. So the continuum of EMR adoption. What I will frequently see with many practices is those practices prepare for implementation. It's a very IT-driven process where they implement their software. It's usually based on templates, and the only way that the practices can get live or health systems can get live quickly is to generally apply a fairly generic template across the entire institution. And so they move through implementation, and over the next either 4 weeks to 6 months, they begin to stabilize. So their physicians, their staff tend to get used to the software. The IT staff fixes the immediate things. They do the break fixes on order entry and on just problems with access and with security. And they get to a level where after 4 to 6 months, they're kind of comfortable with that EMR. And I like to refer to that as stabilization. But what I often see is too many practices stop there. So just to define implementation and stabilization, the focus is on addressing key issues and establishing a baseline of user productivity and happiness. During this phase, solutions tend to be technical, so the IT staff is dealing with most of the issues, and you haven't had a chance yet to really do a lot of the optimization either from the IT side or the operations side. A very important phase that comes next is operationalization, and this is really critical and I think subtle philosophically, but the shift in governments really has to occur at this stage where clinical operations, the people who provide care, whether it's the frontline MA, nursing staff, PA, NP staff, are all knowing what's going on and what type of content changes need to happen. And the physicians need to, from a leadership standpoint, begin to make these decisions and guide the IT staff. So in the operationalization stage, it's the frontline managers, the frontline clinicians, and the physicians that need to begin to tell the IT department the things that they need to work on. But they also need to begin to shift what their focus is and start looking at who delivers what types of care, who is doing what in the system, and is the system supporting it. So you need to have this shift from the IT people who have been responsible for just getting this up and live and running and generally working. And it's a really big job that I hope all of you appreciate from the IT side, to then beginning to have those frontline managers take over control. And then finally, you move to optimization, and that's where hopefully many of you are starting to think about right now and have been working on already. But these are the longer-term efforts to extract business value from your system. And again, the system enhancements are driven by operational priorities and clinicians, and the IT staff continues to move into a more supporting role. And that integration of your IT staff, listening to what your needs are as physicians and as clinicians, is critically important to build over time. And you frequently don't see that as much as you would like to. There's kind of a wall, or the IT staff, once you get live, kind of backs away from what you're doing at the patient care level and at the clinic management level. And if you're out 12 to 24 months, you should really be focusing on your relationship with the IT analyst, the reporting analyst, and other IT folks in your system to get approval to do these higher level things we'll talk about later. So why shift to an operationally driven project? First of all, you as providers know what works for your physicians and your other allied health providers, and you can create a more patient-centered approach to delivering care, where patients don't wait as long, where they have more attention from their provider when they are in the room and not within the EMR. So you can begin to make those shifts. The IT staff, often these are very young people who might even be going through their first implementation, just don't get that. And so it's really critical to shift just for that reason. But you want the changes to be physician-clinician driven. You have local ownership of issues. It generally should become a part of your normal operations to address optimizing your EMR, to facilitate business and operational processes that work for you, and and really importantly for your IT department is to utilize IT resources more efficiently. So you're prioritizing for them. And implementation of an EMR is incredibly expensive, and what normally happens after implementation is that institution really wants to cut way back on their IT expenditures. And so you can certainly help your IT department in this area in that you're prioritizing really well for them as the things that you need to have worked on first and foremost. So hopefully, if you don't just stop at that stabilization phase, and I'll see this very commonly is where physicians will make that decision that they're like, I am only going to see 80% or 90% of the patients that I used to because they're just too overwhelmed by the documentation requirements, or that they continue to spend a great deal of time outside of their normal clinic hours doing documentation and orders and working within the system, is hopefully you don't stop there and become satisfied with that, is that you get to normal productivity or even beyond normal productivity by making some of these changes. And once you pass that operationalization stage, you can move into the optimization phase where you're working on the higher level reporting, the things that payers are really going to want to see, that your clinicians are really going to want to see as they take care of patients. I'll explain a little bit later about one case with a client that I work with that made a great deal of these changes when other parts of their practice did not, and how effective it was for them. But I'll save that for just a little bit later after I go through a few more slides. So specific optimization strategies, and again, these are really operationally driven. These are decisions that you can make as frontline managers, as physicians, as administrators, as to how you deal with the EMR. They don't require budgeting for your IT staff in most cases, and they're things that will require a fairly large shift in culture sometimes for your providers. So again, please feel free to ask questions about these at the end and why I think they work, but I'll try and go through these very specifically right now because I think they can be very helpful to you if you start to think about how you handle your EMR overall at the provider levels. So specific strategies, I've broken these up into EMR specific enhancements that are really enhancements that you can work with your IT staff, but then staffing and workflow enhancements, which I believe are very important. And then in many ways, the most important changes that you can make are changes to your overall service delivery and how you innovate and change. Maybe it's driven because your EMR has made you think about it, but ways that you can think about differently, how you can get more patients through your system, how you can use orthopedic surgeons the most effectively, how you can use all of your allied health staff most effectively, which if a patient or if a physician is used to seeing 45 patients and they only see 38 once they're post-implementation, but all of their new slots are being utilized really well and their ORs are full, which is where really all of your margin comes from, is that your physicians are still going to be happy. And that can certainly be a good thing for your patients, physicians, and providers overall. So some trouble spots from an EMR standpoint that I think are really important to comment on are, first of all, security assignments. It's really critical that once you're going live and after you go live is that your security allows your staff to do as much as possible for your physicians within the system. Whether that may mean entering orders or pending orders or whatever they may be able to do, is you want to be able to optimize and fully enable your providers and not have them held back by security limitations. There are many instances where you see an MA or a nurse, really high quality types of assistants not being able to do what they used to be able to do for their physicians just because you went to an EMR. And so those are things to be very critical about pre-implementation and post-implementation to make sure that you get those right. I think a lot of thought needs to be given to documentation strategy and what is easiest for your physicians to use, whether that is voice recognition, whether that is traditional dictation, whether that is something that is template driven. There are benefits to each one, and also who provides the documentation skills to your physicians and who does that for them is very important to consider. So if you are an institution that really wants to get as much discrete data in the system as possible, save on transcription, things like that, you're obviously going to go more towards a voice recognition or a template-driven solution. But you're also going to see a lot of this slow down your physicians as they're trying to deliver their care, and so you have to look at other solutions if you go in that direction. I think it's really important early on, and I know most of you are past the implementation phase, but to create an implementation which gradually progresses into an optimization team. And this group, as you get to where you are, if you're 12 to 24 months out of your implementation or more, is that they begin to start to talk about what are the higher level things that our system needs to do for us. And so where it might be just fixing things initially and making sure that your IT staff knows what you're doing in the clinic and that you want to apply is many of the things that work post-go live as possible. It then moves into how are you going to address reporting to registries, and how are you going to collect patient outcomes, and how are you going to make the system as smooth as possible for the people who are entering the data, no matter who that is. You want to make sure you're handling orders correctly and making sure that your physicians hopefully are allowing a lot of that to be delegated when it's appropriate for compliance reasons, because it saves a lot of time for them if you're able to delegate them. And you want to have a very smooth order build, so your inpatient orders, your outpatient orders are built and refined, so it's easy for your physicians or other allied health staff to find. You also want to develop a really strong relationship with your reporting analysts and your IT analysts, and especially the reporting analysts are in very short supply right now. But having validated reports that are critical for you from a business standpoint is really important moving forward, and having IT analysts that know what your physicians are doing and know how you function in the clinic is also very critical. So those are some areas that are more EMR specific, just strategies that you want to make sure and think about. But I want to spend most of my time on this related to workflow philosophy and staffing. So if you take anything away from this presentation at a high level, it's that in any system, whether you're in an EMR or whether you're not in an EMR, if it was 15 years ago and you did not have one, and this is very much lean driven as far as from a philosophy standpoint, is you want to eliminate all physician non-value activity that you possibly can. To me, that means maximizing face time with the patients. The physicians want to talk to patients. The patients want to talk to the physician. The physicians want to see patients that they can convert to surgeries. In an orthopedic surgeon's case, those are the patients that they can help. They want to make sure that the patients on their schedule are patients that are going to turn into someone they can help, and that they're going to go into the OR, which is where they generate the most margin, and it's what they like to do the most, is go to the OR, is not spend all of their day in an ambulatory clinic, and then spending a great deal of time afterwards documenting. And we want them to perform only the essential orders and documentation that they have to. And some of that is compliance driven by your department. Some of it is really the physicians being comfortable with turning that over to other allied health staff. I wanted to put this study up. We actually were looking at our utilization of athletic trainers in our sports medicine practice. And this was presented in 2012 at the AMSSM meeting, which are the primary care sports medicine providers. And I'm not putting this up not necessarily to look at how we used athletic trainers and how effective they were in an EPIC environment, but we studied 1,500 patients in this study and looked at where time was spent when they were working within the EMR and over the course of a patient visit. And a couple key things that we found were that over 3.5 hours per day were spent by someone within the system documenting, and that over 4 minutes per patient was spent on just getting the information in the system. And in our case, it was with traditional dictation, because we still do use a fair amount of traditional dictation within our system. So there's a tremendous amount of time spent with just getting the information into the system and getting the right information in the system. You have to make some critical decisions as to who is going to do that. And when you see a lot of physicians talk about this, they'll bring up that I'm spending 3 hours a day extra after my clinic documenting within the system. And our study tended to validate that in that we found 3.5 to 4 hours per day was spent just documenting or putting orders in the system. That doesn't include answering messages and all of the other things that a physician might have to do as part of their business. So smart staffing is critically important, is to fully enable your advanced practice providers, your NPs, your PAs, allow them to move into autonomous practice roles whenever possible. I think they're critical to the future of orthopedic care in that they have to open up that funnel of patients. Not only do they open up the funnel where you can see more patients, but they also help streamline that care, and they help improve your surgical conversion rate and help your patients or help your physicians see the right patients first. But you also have to fully enable your MAs, your nurses, and your LPNs to do as much as possible in the system for your physicians. We also use athletic trainers and our residents and fellows. Not everyone has access to residents and fellows unless you're in an academic institution to help with this documentation and the burden of the documentation as well for our providers. And then finally, scribes, and I think they can be critically useful in, again, these high-volume, high-margin businesses. And I'm going to spend a little bit of time on that in the next 2 slides, just talking about some specific issues related to their utilization. So to scribe or not to scribe, as I think many of you know, the Joint Commission and CMS both recognize scribes, and they define certain standards that you need to follow, and these are defined on their websites if you do utilize scribes. But they are certainly okay to use. They do not take a formal position on them that are saying you cannot use them or you can. But the guidelines are on the website for each of these respective organizations. When to use them? High-volume surgeons and technologically challenged surgeons. So often these are your older surgeons who have trouble keyboarding, who are used to dictation for their entire career, and they just can't handle that transition, especially if you are not allowing them to do any traditional dictation anymore. My recommendations is ideally that you have someone who can document for average 20 to 22 patients daily. And then you need to consider, do you use a formal scribe or fully enabling another allied healthcare provider to do your documentation? If you use a formal scribe, they are going to be a little more cost effective for you, probably in the neighborhood of $20 to $25 an hour. You can pay many of the scribing companies that will supply these people to you, or you could train them and hire them on your own. Or you can keep an allied healthcare provider, or you can use an allied healthcare provider who are going to be a little more expensive for you, but will tend to know your physicians. They're going to tend to stay longer, and they're going to be more engaged because this is really their career choice. So you have a couple of choices about who can scribe, but the rules around scribing your physicians really don't change depending on who you use. The impact of scribing. First, this is one of the areas where I think it's critical for physicians to be open to a change in service delivery and culture. Is even if a compliance department is comfortable with allowing scribing in their institution, there are many physicians who don't want to turn over that responsibility to other providers. And what you see after you allow other physicians or other people to scribe or document for you in your system is improved patient satisfaction, improved provider satisfaction, and the documentation actually becomes enhanced from a content standpoint and a billing standpoint. This is their job, is to get content into the system accurately and reflecting what the physician wants in their note. And there is a fair amount of time spent up front in educating the scribe or the allied health provider to make sure they're getting the right content in the notes and that they're saying the right things. But after they're comfortable with that provider and what that provider is telling patients, and in orthopedics, there are many parts of orthopedics that the recommendations are very standard or consistent to patients, is the notes become very good. And when you have providers who move to this, they would never go back, because you're eliminating probably 80 to 90% of what they have to do from a documentation standpoint in the system. And when you do add a scribe, or when you do fully enable another individual to document, I will always recommend piloting this early with 1 or 2 providers who are very supportive, and then also adding approximately 10% of patients back into the schedule. One of the clients that I worked with, going live in 2 separate practices for orthopedics. One went live 6 months before the other one did, and one of the joint replacement providers in this practice had a really good LPN, and he allowed that LPN to work in a note writer template, and this is an Epic client, to fill in a great deal of the history in advance of him seeing the patient. And all of the other providers in that practice who didn't do that were down 10 to 20% 6 months later in their volume. And he was, because he made that change, he was actually up 10%. And the Chief Medical Information Officer asked me about that at our exit interview, and we were talking about it, and said, what do you think about this? The other physicians really didn't know if it was appropriate. Their compliance department really didn't know if it was appropriate. And I provided them background information on scribing and some other studies that had been done that demonstrated 10 to 20% improvement by allowing, in volume, by allowing other people to enter data for your physicians. And again, it would seem intuitive, but this was like one example that was brought to me, without me even trying to teach this institution how to do this. And so it's very important to think about this as a possible solution for your really high volume providers, but don't just stop at scribing. Let the individuals in your clinic do as much as possible for your physicians, again, so they can spend time on those value-added activities that we mentioned earlier. One area that I think is really important to note is on HPI documentation. There was a 1997 CMS rule, again, pre-EMR, that defines the history of present illness, and this is only for the history of present illness. The rest of the documentation, CMS does not have any rules about as far as who can document, but it defines HPI documentation to be the responsibility of the provider. And if you talk to your Medicare carriers and look at their interpretation of this rule, I think it's important not just to accept that first bullet, because the documentation in many cases by carriers, when they interpret the rule, is that the responsibility of HPI is on the physician, but documenting it may be performed by a scribe as long as they are in the room and record the information in the presence of a provider. So this seems to be the case in really even conservative interpretations of this rule. But even if your institution takes the most conservative approach possible and their Medicare carrier says, yes, only the HPI has to be taken and it has to be entered by the physician, is don't lose sight of the overall value of using other allied health providers or scribes to do more for your physicians. And again, that 3.5 hours per day spent in the system when your physician can be doing something else is critical to take a look at. So I just wanted to bring that up because it is important, and we certainly want you to follow the guidelines of CMS related to documentation. But it's very important to not just take that at face value, as ask your Medicare carrier and get an interpretation. So what does this look like ideally? I'm just going to roll through a few slides really quickly. Is hopefully your person who are you having in your clinic, whether it's your MA or other allied health staff or a scribe, is taking chief complaint, doing their pain scale rating, vitals, pain, past medical history, medication reconciliation. They're doing all those things in Epic during their rooming process. That's probably pretty standard within all of your institutions. But if you take another step forward and allow them to perform a brief history, do a physical examination, order radiographs. Again, we use our athletic trainers, residents, and fellows to do a great deal of this within our setting at the UW Hospital, and you're seeing this increasingly in other entities. But then they can also start the documentation on that patient. And what allowing them to do a brief history, physical exam, start the documentation allows them to really effectively present the case and refine it when they present to the physician. So they might have to order radiographs, again, under delegation from the physician and under protocol. If they can do all those things, so before the physician even comes in, all of those things are kind of taken care of. And step 3 really has 2 parts. This is what we want, is the physician talking to the patient. It's the physician FaceTime, but then it's that extender, whoever that may be, whether it be the scribe, whether it be another allied health provider, is documenting the history of present illness while the physician is in the room. Even, again, like we said, a very conservative interpretation of that rule is they can go back in and document HPI as well as the rest of the note while the physician's talking to the patient. So they can start to do the order entries for rehabilitation or durable medical equipment or consults to other providers. So they can at least start and maybe finish the documentation while the physician is talking to the patient. In step 4, after the physician leaves the room, is this individual knows that physician, and that patient is probably going to have a few more questions, and they may need to have DME fitted, or they may need a letter for their work or a letter for their school, and their ABS may need to be prepared. Well, that allied health provider can then do all of that while the physician's already moved on to the next patient and are seeing them. So in an ideal world, and there are many different ranges of how institutions use allied health staff, is that this provider is doing the bulk of the visit, but this is when the physician is in the room, that patient has their full attention, and they're able to talk to the patient and answer as many questions as possible during that time. One metric that I think is critically important for you to measure if you are not already is the surgical conversion rate. I think this is a great overall measure of how you're doing everything within your clinic: scheduling, registration, your access, your triage and patient placement, how you use your staff, your physician utilization. And there's a very interesting study done in Canada, which, you know, I guess you can say we're tending to move closer to this, as all individuals will have access to health care. And this looked at every patient who saw an orthopedic surgeon in Ontario over the course of a year. And this was actually in 2004 and 2005, but just published this last summer. And 79.3% of the patients did not receive surgery after 18 months, so a 20% surgical conversion rate for that time frame. And I certainly know our physicians and our surgeons especially wouldn't be happy with a 20% surgical conversion rate, and that we can do a lot better. And I think it points to the need to shift our care to doing everything better, all of our access programming and triage, and then how we use all of our staff. I think it's very important in orthopedics to also consider the cost containment versus revenue generation debate. Do you spend more time, or do you spend a few more dollars on staff in order to allow your physicians to keep their ORs full, keep their clinics full, seeing the right types of patients? When you're in a specialty like orthopedics or subspecialties like sports medicine that are very high margin in spine and joint, is when for every patient you see that becomes an operative patient, you are making more money for your practice. Spending that extra money on those extra staff to possibly allow you to see 5 or 10% more patients in a day is critical. And if you can combine that with making your physicians and patients happier, that's even better. So takeaways: fully enable your extenders, maximize your surgical conversion rate, which helps on your overall volume and how you're dealing with your days anyway in an orthopedic practice. Decentralized build is start to have some of your providers at the front line begin to do builds for your physicians as far as content. Create an optimization team and really integrate your IT analyst. But innovation is critical. We talked about a lot of this already, but don't be afraid to start to look at different ways to deliver care that allow you to get the right types of patients in your surgeon's clinic. And we really like to build around the philosophy that everything revolves around the orthopedic surgeon and how we can make them more effective and support them in the most effective way. So leveraging your investment, just a few more slides before questions. I think what we are now looking at, and this is Vernon Weckworth, who ran my executive study program that I went through at the University of Minnesota. He was a statistician, and this is a quote that I took away from him, is that I am becoming increasingly convinced that what is truly important in healthcare is inversely related to what is easily measurable. And I believe that is very true as I start to work with higher level workflows. It's how we get information into and out of our system for registry reporting, functional outcomes reporting, quality and safety reporting, and then the analytics. And it really involves a marriage between your IT staff and your operations staff in order to get these workflows down right and have your patients help you get data within the system as well. So just a few specific areas to mention as far as the registry and the outcome side. The AJRR is working closely with all of the EMR vendors right now. I've worked a lot with them with Epic. They're sponsored by AAOS and industry. They have 235 plus pretty large institutions, and they're growing very quickly. And we're working to the point where our EMR automates our reporting to AJRR. And not only AJRR, but other registries are being looked at now by payers. And if you report to these registries, you may be in a preferred payer rate as compared to some other potential competitors. And that is the same for functional outcomes. We are also pursuing a membership in the Own the Bone Registry, which is sponsored by the AOA. It's a fragility, fracture, and prevention registry. It requires data entry as well as patient education to hopefully prevent secondary fragility fractures. The North American Spine Society is developing their own registry for spine care. So where we may have a handful of registries right now, there may be 10 to 12 in the near future where we have to coordinate our EMR and hopefully automate reporting as much as possible so we're involved, or so more institutions are involved in this. Patient-reported outcomes. So these are scales such as your WOMAC SF36. Some of these are now being built into EMRs, but again, getting data in and getting data out is very challenging and requires a lot of thoughtful process improvement changes. You can look at tablet options, kiosk options, your EMR portal options, and the EMRs, again, are being asked to do this by more and more clients, and a lot of this functionality is just starting to occur. You have to have real-time access to your outcomes data, which our physicians really have never had before in many cases. They can get outcome scores, but they often have to run a report after the fact, and it's not available to them when the patient sees them. And they'll be able to show them that, which I think is very important moving forward. Quality and safety reporting can be facilitated and automated by your EMR as well. And your business analytics is because all of you are, nearly all of you are on all-in-one systems, all of this can be integrated. You can mine that data, and there are many companies, whether they're third party or whether they're your own vendor, that mines data and can get you data like you've never had before. So think about that thoughtful utilization as well. So I'm going to end just with this quote by Albert Einstein: "His problems cannot be solved with the same level of awareness that created them." And to me, obviously, this means that we need to apply different solutions in this new environment of healthcare service delivery. And I think hopefully that came across today throughout my presentation. And I'll end there and want to again say thank you to WellBe and take some questions.
Thanks, Joe, for that informative presentation. We will now open it up for questions. If you have a question for Joe, please submit it into the questions box in your GoToWebinar panel on the right side of your screen. While attendees are submitting questions, I want to remind everyone that today's webinar is sponsored by WellBe's Guided Care Path. Currently in use at Joe's facility, the University of Wisconsin Hospital and Clinic. Guided Care Path is a patient-facing technology that helps create a single streamlined patient experience through the entire journey of a total joint replacement. It creates a continuum of connection between patients, their family, and their providers. Smart checklists are delivered in time, just in time as patients progress through their care plans. The information is always there for reference when needed, in case preparation or follow-up instructions are forgotten. This helps reduce patient anxiety and improve outcomes. To request a 3D demonstration of a WellBe Guided Care Path, please respond to the poll on your screen. Joe, our first question asks, our physicians feel that the personalization of patient care has been taken away with the use of EMR. Do you have any strategies to address this?
Yeah, I think, again, a very common piece of feedback that I get, or a common complaint, is I think one of the things that that was probably a good decision by our institution, at least early on, was to continue to allow for traditional transcription to reflect, rather than in a template format, what was done during the course of that visit. And so we continue that now, and I think we'll probably be making a shift. I know we're making a shift to more template-driven care, but I think that, or template-driven documentation. But I think that being able to allow your other allied health providers to be a part of that care, and really they're functioning as a delegate from you, is really critical, that the physician doesn't have to do all of the parts of the visit by themselves, or as much as they were used to doing. Is some of the best patient satisfaction scores that I see out there when physicians actually do delegate to other individuals, and they allow their PAs and NPs to do more. They allow their residents or athletic trainers or other people assisting them in the clinic, their MAs, their NPs, to do more for them, and because they have time to spend with it. And physicians get so rushed in this day and age, thinking, I just have to meet all the requirements of meaningful use. I have to get everything in the system. This is all my responsibility. So I think moving along that continuum where you take some of those things that a physician doesn't want to do anyway out of their hands, and allow others to spend more time with the patient, and allow that physician to have that face time with the patient is critical. So, so spending quality time with the patient, I think, is what's most important. Not entering a lot of data in a note writer, or trying to complete all your orders in the room, or doing your bills as efficiently as possible. Is let other people do those types of things for you, certainly within the compliance guidelines of your institution. But I think that's where, you know, personalized care can even benefit after an EMR. It's one of those examples that I think is one of those shifts that you don't think about until this drives it. And I think use this change to drive it.
You mentioned meaningful use, and we have a question here from Paul, who asks, how do scribes impact meaningful use? Meaningful use.
Yeah. Again, this is something that is dependent upon your institution's opinion on what means meaningful use. Like when you are being asked to do medication reconciliation, to ask for chief complaint, ask for pain scores, and to validate that that's done with every visit, or review that with every visit, it's not clear that the physician has to be the one who is doing that and asking those questions. And I would argue, in fact, that the physician, if they're not doing it, shouldn't be just going and clicking buttons if they're not the one asking all of those questions and doing those validations. So I've seen different interpretations, but to allow the other allied health provider to do those things still meets meaningful use requirements. It just has to be done over the course of that visit. It has to be done by someone over that course of that visit. So, but whoever asked the question, I'm certainly happy to talk to them more after this visit on some different approaches to that. But I know most institutions feel that whether it's a scribe or whether it's a fully enabled allied health provider, doing the bulk of the visit in this case is helping to enter orders and things like that, as long as it's under protocol and it's delegated to them, that they're okay with that.
We're at the top of the hour. Maybe time for one more question. Joe, where do you think EMRs are going next for ortho? What do you see in the future?
Well, I think what is going to happen is that, and we're already seeing this, is that the vendors are going to create more specific products for each specialty. They were implemented because the all-in-one products have been implemented because they allowed all parts of the institution to talk to each other. And with that, you lose that customizability for each area. And I think where the products are now going to be going are that they are going to start to refocus on building the best possible module and product for each specialty, and then making it more usable for the providers as well, and so to speak, Appleizing the software so you can navigate it as easily as possible. But I think you'll see more customization, more ability in orthopedics to automate reporting,
to collect data from patients, to report to registries, where it's just not a module where you're recording the transaction anymore, where you're able to do a great deal more with it.
Hey, well, that's all the time we have for today. If you have questions you didn't have a chance to ask, feel free to email them to info@wellbe.me, and we'll get back to you. Otherwise, watch your email tomorrow for a link to the recorded presentation and a PDF of the slides set. Thanks for attending, and everyone have a great rest of your day.